Hi, okay, we're going to in this video talk about studies that look at questions of therapy. And so that really refers to any kind of drug that has some sort of beneficial action for our patients. So that may be something that prevents something bad from happening to them, like bad symptoms or death, or something that will make something good happen to them, like a cure. And again, we're going to be using the Sackett and Guyot rubrics for looking at articles. And those, remember, you ask three questions. You ask, are the results valid? What are the results? And how can I apply these results to patient care? And in order to answer those questions, you need to answer a whole bunch of other sub-questions that we got listed here. We're going to go over all of these real quick. And so studies of this type are usually going to be randomized controlled trials. So let's review this study design quickly. And so the randomized part means that you're going to split people into two groups, and how a patient gets selected to go into one group or the other is at random. Controlled means that you have one group that receives a treatment, and that's called the treatment or the experimental group, and the other one gets nothing. And these are the controls. And even better than nothing is for that control group to get a placebo. And a placebo is a drug that looks like the drug that the treatment group is getting, smells like it, tastes like it, whatever, but it has no drug in it. It's just sugar water or a sugar pill. And so any psychological effects or anything that taking the drug would also occur in the placebo group. So that's the controlled part. Then a trial means that we're going to try it out and see what happens. So you split them into two groups, and then one gets a treatment, the other one gets the placebo, and then you measure some outcome at the end. Like perhaps you want to see how many get better. And you also want to see how many die in each group. And then you tally them up, how many got better, how many died, how many got better, how many died in both groups, and you compare. And so that's our randomized controlled trial. So the first question we're going to ask are the results valid? And there's really two main questions we want to ask. Did the control group and the experimental group start out with the same prognosis, meaning were they both similar in everything that matters? Were they both equally sick? Were they both equally as old? And at the end, were they both kind of similar? Except, of course, in the thing that we're measuring, were they similar in other ways? And so first let's take a look at this first one. Did they start out the same? So let's look at how we're going to answer those questions. We're going to look at really four things here. Were the patients randomized? Was a randomization concealed? Were the patients analyzed in the groups to which they were randomized, and were they similar? And so you don't even have to do randomization. Some studies don't have randomization for one reason or another. Maybe it's just not convenient to do so, or maybe the physician picks which patients go into which group. So you can see this is fraught with bias. Maybe the good-natured doctor believes that the treatment helps, so wants to put the sicker patients into the one that's getting the treatment. Or maybe they have a vested interest in proving that the drug works, so they're going to put the healthier patients in the treatment one, so that when people are dying off just from other causes, there's going to be more dead in this group than the treatment group. And so remember that the power of randomization is that the treatment group and the control group are more likely to be balanced with respect to all different factors, especially those things related to the outcome. So those confounders that we talked about before. So the confounders will be balanced. So if we let randomization play its role, then we're more likely to have balanced groups. But it doesn't have to be, even with randomization, you could have bad luck and have all of the square heads in one group and the circle heads in a different group. But the greater number of patients you have in each group, the less likely that is to happen. That's why sample size matters. So the next question we need to look at is, was randomization concealed? And I think this is best demonstrated by the story of a study that was done where patients presented with right lower quadrant pain and needed appendicitis, and they were going to be randomized to either have open surgery, where they cut the patient open, or laparoscopic, where they used cameras to do it. Now, the laparoscopic one took longer, and you had to call in the attending surgeon. These were residents who were doing this. And so at nighttime, that was a pain because they had to call in this doc who then had to come in. And so what they were doing was taking the envelope, the sealed envelope that had open or closed in it, putting it in front of a bright light so they could read what was inside. They'd find the one that says open, and they'd open up that envelope. So obviously this is going to introduce some bias here, right? And so the better way to do that is to call into some randomization center and they tell you open or closed. So the next question is, were the patients analyzed in the groups to which they were randomized? So let's take a look at this over here. And what might happen is that everyone in the placebo group thinks, you know what, I'm not feeling well. I want to get some of that brand new treatment. I'm going into that group too. And then the other person over here says, yeah, I don't feel so good either. I'm going into this group over here. And so these sicker patients that we had that were randomized to go to the placebo group decided, I'm not going to follow that. I'm going to go to the treatment group. Another way that this might happen is that the people in the treatment group might decide, you know what, I don't feel well. These medicines are making me sick. I'm going to stop taking the medicine. So they've effectively put themselves in the placebo group at this point. So you can see now how this would bias the results, right? Sicker patients are going, they're picking where they want to go. And so if you were to analyze it like this, you'd say, okay, well, all the sicker patients are in this group and the healthy ones are in this group. That would bias the result. Another way that this can happen is that maybe the treatment is surgery, and these people die before they get surgery. So they effectively have had no surgery. Not by any fault of theirs, but they just died before that could happen. So again, you're going to have sicker patients in the no surgery group. So the way you deal with this is you say, I intended to count you guys over here as the surgery group, so I tended to treat you like that, so that's how I'm going to count you when I do my analysis. And that's called intention to treat. What that means is you guys can go to whichever groups you want to. I'd prefer if you didn't, but if you go to another group, I'm going to count you in the group I intended to treat you in. And the reason you do this is to preserve the value of randomization. That is, that the prognostic factors, that those confounders, are equally distributed among both of those two groups, despite the fact that they're moving around between groups. Okay, and the fourth one here is where the patients, the treatment group, and the control group similar with respect to known prognostic values, or that means like known confounders or known other things. So are there the same amount of smokers in each group? Are there the same amount of old people? Are there the same amount of men? Are there the same amount of women in each group? And for the things that you know, you can adjust for that. For the things that you don't know, you can't adjust for because you didn't measure those things. You don't know that those are the confounders. And so you want to see that that they are about the same. And again, that's the power of randomization, is that they will hopefully be the same if you have a big enough sample. Now let's go to the next question, which is, did the experimental and control groups begin and end? Did they end with a similar prognosis? And then there are 4 questions that we look at over here. The first of which is, were the patients aware of group allocation? That means, did they know if they were getting treatment or control? So if the control group is getting a shot and the placebo group is not, then obviously they can tell the difference, and the control group is saying, I got a shot of something good, that's probably going to make me feel better. And the placebo effect alone, even if there's nothing in there, can make them feel better, whereas a person who got nothing will not feel better. So it's always good to use a placebo. And yes, that means you're giving a shot of just saline to somebody that has, and that might not seem fair, but that's how you got to make the study go well. And there have been studies where the control group got surgery and the treatment group got surgery and the control group got a fake surgery. They made it seem like they got surgery. They even poked holes in this person's knee, splashed water around, and did nothing, and pretended like they got surgery to see who would do better. All right, the next question. Were the clinicians aware of group allocation? Did they know who got the treatment and who didn't? Maybe the patients who get treatment get a lot of extra attention from the physicians, and the control group gets none. And this extra attention itself, this extra care, might explain the treatment effect that we see. So the people taking care of the patient should not know the difference between who's in treatment and who's in control. And the other person who should not know the difference is the person who is assessing the outcomes, right, between the treatment and the control group. So they might look more closely in the treatment group to see if they got better, and they might kind of ignore some things in the control group. Now, if it's some obvious outcome where there's not much judgment involved, like did the patient die or not, it's pretty easy to know if someone died, right? You're not only kind of dead. And so in those cases, it's less needed to have blinding. But in the ones where it requires some judgment, like did the patients, are they feeling worse, right? Maybe it's a subjective call, and then it's very important that they are blinded, because they might say, well, these guys, they got the medicine and I think they're feeling better, and these guys, well, yeah, they're definitely feeling worse, where they might be feeling the same, right? So it's important that these guys are also blinded, the outcome assessors. And the last question we got to ask in this series of questions is, was the follow-up complete? So again, we have our study over here. We're randomized to experimental control, and these guys go through. But this one patient over here says, you know what, I feel too sick. I'm out of here. And they leave the study. So what if sick people are leaving the study because they're not getting the drug? That's going to bias your results. Or maybe the well people are leaving the study. They say, this is just too inconvenient for me. I'm getting out of here. And so the well people leave, leaving only sick people in this control group, which makes the drug look better than it is. And so this is called loss to follow-up. Because we're going to have no data on this person. They're completely gone. Remember the people who switched groups? We still have data on them. They stayed in the study. They just didn't stay where they were supposed to. This person just left altogether, so we have no data on them. And so you may hear that rules of thumb, a loss to follow-up rate of 20% is or less is good. But that's a bit misleading. Because let's say that if only 5% of each group suffers this outcome, let's say death, and 20% drop out, how do you know the real outcome? Maybe the 20% who left were all alive, or maybe they all died, and that's going to change your outcomes a huge amount. And so I think really the loss to follow-up, it really matters. If you have a 20% loss to follow-up, but you also have a 20% outcome rate, then everybody who left could have died, right? Or everyone who left could have done well, and that's going to completely skew your results. So it should be maybe 20% of the event rate that you're seeing, or some small number. And one thing you can do is you could just assume the worst. Be a pessimist. Assume the worst for this guy. And the worst doesn't mean that he dies, right? In this study, let's say that he gets better, right? Because we want to prove that our drug works, so we'll say the guy who left actually got better. It's good for our study. And let's say somebody left our experimental arm. So to make the worst case scenario for that person would die, because we want to prove that the drug works and it didn't work for them, so they died. So that's one way to take care of loss to follow-up. Okay, so that's the end of this video, because we just covered only are the results valid and a whole bunch of questions that pertain to that. Next, we're going to look at what are the results and how can I apply them to patient care. Thank you for watching. See you later.